Hello, my name is Paul Perrin, and I'm an assistant professor in the Department of Psychology at Virginia Commonwealth University. My primary appointment is in the health psychology doctoral program, and some of my research interests focus on multicultural health psychology. So I study how the impact of different people's or different forms of people's identities affect their health behaviors. So things like race, ethnicity, sexual orientation, and gender. Today, I'm going to be talking about culture, caregiving, and stroke rehabilitation. So the title of my talk is Developing a Systems Lens, the Importance of Culture and Caregiving in Stroke Rehabilitation. So I'd like to start by paraphrasing a Jerry Seinfeld joke. Now, in one of his stand-up routines, Jerry Seinfeld says that going in to see your doctor is the only meeting that you have all day where you go in knowing that you're going to have to take your pants off. And in fact, you go in knowing that you're going to have to take your pants off and sit there for 15 minutes before anybody will even come and see you. So as you're sitting there with your pants off, people come in the room, they leave, they come in the room, ask you some questions, leave, all of them wearing pants while you're sitting there with no pants. And Jerry concludes his joke by saying, in all matters of medical decision-making authority, pants always beats no pants. Now, I think that Jerry Seinfeld's joke is actually very insightful and says a lot about healthcare. Now, the patient-provider relationship involves a pretty strong power differential. And when you have providers who are from ethnic majority backgrounds and patients from ethnic minority backgrounds, that patient-provider power dynamic actually amplifies power dynamics that are present in society more generally. So as a result, it's incredibly important to consider the effects of culture on the patient-provider relationship and in rehabilitation more generally. So that's what we'll be talking about today. Now I'm going to present to you the results of 5 different papers that my research team has been working on. In the first paper, we created a structural equation model, and I'll talk to you a little bit more about what a structural equation model actually is. But we created a structural equation model of a feedback loop between caregiver mental health and stroke functioning in the United States stroke belt. In the second paper, we tested this feedback loop longitudinally in an ethnically diverse sample. Then in the third paper, we examined the connections between caregiver mental health and racial and ethnic disparities in stroke. In the fourth paper, we used some of our findings from the first 3 to develop and implement a randomized controlled trial of a problem-solving and educational telehealth intervention primarily for Latino stroke caregivers in Puerto Rico and Texas. And in the 5th paper, we advocated that a cultural or a systems lens should become a part of the standard care for stroke rehabilitation. So to start out with, I think it's important that we sort of establish a basis regarding what we're talking about. Now, I know that a lot of you know what stroke is, but just to go briefly over it. So there are two main types of stroke. The first is a hemorrhagic stroke. In a hemorrhagic stroke, blood leaks from a blood vein or a blood vessel into the surrounding brain tissue and kills that surrounding brain tissue. And the second type of stroke is an ischemic stroke. In this type, a blood clot develops either in the body and passes up into the brain or develops in the brain itself. And it causes a block of blood flow to a particular brain region. And as a result, that brain region doesn't get oxygen, and within about 3 to 4 minutes, that brain area begins to die. Now, in stroke intervention, there's the common saying that time equals brain. So literally, within about 3 to 4 minutes, that area of the brain starts to die. And as a result, it's incredibly important that stroke intervention happen quickly, either to remove the blood clot or to stop the bleeding within that particular brain area. So let's talk a little bit about stroke. Now, each year in the United States, about 700,000 individuals suffer either a new or recurrent stroke. And because medical technology has improved recently over the last couple decades, a lot of people are living with the effects of stroke, so surviving stroke and then living with the disabling components of it. So currently, 5.6 million Americans are living with the effects of stroke. And what this actually does is it positions stroke as the leading cause of disability in both the United States and actually in the Western Hemisphere. Now, there are a number of different deficits that are associated with stroke, but this really depends on the particular brain area that's damaged. A common one is motor problems. So people might lose motor control over one of their limbs or over one side of their body, sometimes one side of their face. They may walk with a gait, have difficulty with balance and controlling their motor movements. People can also have cognitive problems where they might have a hard time inhibiting impulses. They may have a hard time speaking or engaging in different types of executive functions like complex planning behaviors. They may also have emotional problems where they might laugh wildly at a funeral or cry at a birthday party and have kind of inappropriate affect in certain situations. They may also have alexithymia, where they're unable to experience any emotions at all. So the emotional components of stroke really are pretty wide-ranging. Also, people with stroke may have communication problems afterwards. They may have aphasia. They may have a difficulty pronouncing words because of motor problems. Or if stroke hits particular communication areas of the brain, they may have difficulty speaking or understanding verbal communication. Now, stroke actually affects particular areas of the United States more so than in others. And mortality disparities exist through the southeastern United States. Now, as you can see, this goes from Alabama and Georgia up through Virginia. Now, this is actually called the United States Stroke Belt because mortality rates from stroke are so much higher here than in just about any other region. Now, because a lot of people are living with the effects of stroke, it's incredibly important that stroke caregivers take part in the caregiving process, in the stroke rehabilitation process. Now, stroke caregivers actually save over $200 billion a year in healthcare costs in the United States. So a lot of the care of individuals with stroke is falling on informal caregivers, which are typically family members, loved ones, close friends, or neighbors. Now, when a person has a stroke, the caregiver has to adjust to a couple things. So one of the first is the effects of the stroke on their loved one. So if you can imagine your spouse having a stroke and now no longer being able to communicate with you or to be able to do a lot of the things that they used to do, there's a huge adjustment process that caregivers have to go through just because of the loss of functioning to the individual with stroke. Also, caregivers have very little time to adjust to their new role. So as soon as the person with stroke is discharged from the hospital, the caregiver has to take on a huge change in their role and living situations pretty often. The caregiver has to adjust their lifestyle and now start to provide care that's often physically and emotionally draining. Many caregivers provide informal care 24 hours a day to the individual with stroke. This can include things like helping the person dress or bathe or eat, or taking the individual with stroke to a number of their healthcare appointments. And because of this tremendous amount of caregiving that caregivers tend to engage in, they've been shown to experience very high depression, anxiety, burden, and burnout. Now, depression rates for caregivers have actually been estimated at about 40 to 50%, where about 40 to 50% of caregivers meet the clinical threshold for depression. Now, depression and a higher effect on their mental health has been linked to more basic care responsibilities, like feeding, helping the person with stroke use the restroom, and also to less successful stroke recovery. So the lower a caregiver's mental health, the less successful stroke recovery will be. Now, caregivers also experience pretty high rates of physical health problems, especially sleep disorders. One of the personal experiences that I had with caregiving wasn't with stroke, but actually with Parkinson's disease. So my grandmother, a number of years ago, was diagnosed with Parkinson's disease, and my grandfather became her caregiver. And I remember toward the end of my grandmother's life, my grandfather cared for her pretty much 24 hours a day. And he got to the point where he developed this huge hernia in his stomach from having to lift her every single day, multiple times a day. And he would not go and get that hernia checked out or taken out because it meant that he wouldn't be able to provide care for her for about 2 to 3 months. So, a lot of caregivers actually fall into that same situation where they neglect their own health care and their own health problems, really to sacrifice for the individual with stroke. So this brings us to our first study. Now, the title of the study was called Structural Equation Modeling of the Relationship Between Caregiver Psychosocial Variables and Functioning of Individuals with Stroke. And this study was published in Rehabilitation Psychology. Now, in this study, we examined the connections between the mental health of stroke caregivers and the functioning of individuals with stroke in the United States stroke belt. So up until this point, there had been a lot of kind of simple, straightforward bivariate correlations that researchers had uncovered. So for example, depression in the stroke caregiver was significantly correlated with depression in the individual with stroke. But what we decided to do is look at this in a more kind of holistic way. And we wanted to examine overall how caregiver mental health and stroke functioning or stroke recovery were related. We wanted to examine the magnitude between those two sets of variables. So in this study, we had 135 dyads participate, so 270 participants overall. And these individuals were all from North Florida and South Georgia in the Department of Veterans Affairs. So this was right at the bottom of the stroke belt. The racial and ethnic breakdown of the study, 10 were black, 1 was Latino, and 120 were white. All 3 were other. So for the most part, this study involved white individuals from the United States stroke belt. Now this is what we uncovered, the structural equation model. I know this looks pretty intimidating, but if you give me a minute, I'll break it all down for you. So in a structural equation model, there are 2 types of variables. There are manifest variables, which are constructs that you measure directly. And then there are latent variables, which are constructs that you infer to exist. So they're kind of like umbrella terms that encompass your manifest variables. So in this model, our manifest variables are those that are represented by boxes. So we assessed over on the right caregiver depression level, where we just gave caregivers an inventory of depression, and they had a particular score where higher scores meant more depression, and that's literally our manifest variable because we measured it directly. So we also measured caregiver burden and caregiver sense of coherence, which is sort of coping ability. It's a person's ability to make meaning out of difficult life experiences, so kind of a cognitive framework that people impose on maybe suffering or challenging events that they go through. And then in this side of the equation, caregiver mental health was the umbrella term variable. So this is our latent variable represented in a circle. And then what we have is these loadings or arrows going from one to another, which can be just sort of interpreted like correlation coefficients, where the higher the loading, the more significant the relationship between those 2 variables. So down here at the bottom, we have our care recipient or person with stroke severity variables. Over on the right, we have language ability. So this was an aphasia quotient. Then we have care recipient depression, care recipient stroke impact. So how heavily the stroke is impacting the person. And then we also have a measure of stroke recovery. Now all of these variables together combine to create this latent variable called stroke severity. Now, the thing that we were most interested in was the size and the direction of the correlation between caregiver mental health and stroke severity. And what we found was a negative 0.31 correlation, which was statistically significant. And what this meant was that the higher a patient's stroke severity, the lower the caregiver's mental health was. Or, inversely, the lower the caregiver's mental health, the higher the stroke severity, or the less stroke recovery that was happening. Now, the way that we interpreted this was through a feedback loop. And you can actually start anywhere in this feedback loop, but we'll just start over here on the right-hand side. So an individual has a stroke. Now, this is very hard for the caregiver to take. You know, if a spouse or a loved one has a stroke, then obviously their family members are affected by that. So the heavier the stroke, the lower the caregiver's mental health. And the lower the caregiver's mental health, the lower the quality of informal care that they'd be able to provide. The lower the quality of informal care, then the lower the stroke rehabilitation will be. So this negative feedback loop can operate. But on the other hand, if a caregiver has positive mental health, what that can do is lead to better informal care and as a result better stroke rehabilitation, which then produces better mental health in the caregiver. So this feedback loop can also be positive if in the right direction. So for paper 2, we decided to examine this feedback loop longitudinally and then also use a more ethnically diverse sample. So we published a paper also in Rehabilitation Psychology, which was called Identifying At-Risk Ethnically Diverse Stroke Caregivers for Counseling, a longitudinal study of mental health. Now in this study, we used an ethnically stratified sample. So we had 124 dyads overall, or 248 participants. And in this sample, about a third of the dyads were black, a third were white, and a third were Latino. And we sampled both caregiver mental health and stroke functioning at 1, 6, and 12 months after hospital discharge. So two sets of variables that we cared about, caregiver mental health and stroke functioning. And we sampled this over time. Now, I know this thing looks even more complex than the previous diagram that I showed you, but I'll walk you through this one too, I promise. So, we created a cross-lag panel design. And in a cross-lag panel design, what you do is you sample two variables over time, or two sets of variables over time, and you look at the relationships between the two, or the cross-relationships over time. So here we're sampling care recipient functioning at 1 month, caregiver mental health at 1 month, and care recipient functioning at 12 months, and caregiver mental health at 12 months. Now over here on the left-hand side, care recipient functioning was comprised of functional independence, so how independent the individual with stroke was, their instrumental activities of daily living, which are kind of the higher order activities of daily living, like social functioning, being able to use a remote control, being able to kind of do the activities that you want to do. And then we also sampled their depression levels. For the caregiver mental health variables, we assessed their sense of coherence, so again, their kind of coping ability or their meaning-making ability. We assessed caregiver burden and caregiver depression. And then we assessed those two sets of variables in exactly the same way at 12 months. So I'll let those fade away. Now in a cross-lag panel design, the most important things that you're looking at are the cross correlations. So the correlations between care recipient functioning at 1 month and caregiver mental health at 12 months, or caregiver mental health at 1 month and care recipient functioning at 12 months. Because what you can actually do with a cross-lag panel design is you can help establish causation. So we were interested in seeing which of those sets of variables actually caused the other set of variables. Now, in this design, we actually found that neither set of cross-correlation was statistically significant. So we couldn't really infer causation, but this did provide some indirect support for our feedback loop model, where each set of variables causally influenced the other. What we did find, though, was down at the bottom, caregiver mental health at 1 month significantly predicted caregiver mental health at 12 months. So we decided to break that correlation apart. And we wanted to see, well, what particular variables at 1 month post-hospital discharge predicted poor caregiver mental health at 12 months. And what we found was that caregivers at 1 month who had a low coping ability, who had high burden, and who also had high depression and cared for a low-functioning care recipient had poor mental health at 12 months. So what we were able to do was establish a rubric for determining which caregivers at 1 month were most at risk for experiencing poor mental health at 12 months. And as a result, our suggestion was that these caregivers, the ones who had low coping, high burden, high depression, and who cared for a low-functioning care recipient, those were the ones who are most in need of mental health support. Now, this study was actually featured in the APA's Monitor on Psychology, which is the flagship magazine of the American Psychological Association. And down at the bottom, they quoted me, which I think is probably the most important quote, and I'll read this to you. Rehabilitation programs that only focus on the stroke patient may be approaching rehabilitation with only about half the power they potentially could. And that's something that I firmly believe. It's incredibly important to include caregivers and family members in the rehabilitation process. So, we were interested then in bringing in race and ethnicity, or understanding how racial and cultural background affected all of these variables. So let's talk a little bit about how race and ethnicity affects stroke rehabilitation. Now, research has shown that Black and Latino individuals experience more strokes and recover more slowly from stroke than white individuals do. And as compared to whites, Black individuals are twice as likely to sustain a second stroke, whereas Latinos are 2.6 times as likely. So these are actually major disparities, both in the prevalence and course of stroke rehabilitation. Now, one possible contributor to these racial and ethnic disparities could be differential types of informal stroke care that people with stroke receive. Now, what research has shown is that the the care structures of different racial and ethnic groups actually tend to mirror the levels of collectivism in the overall caregiver's culture. So research studies have shown that overall, and again, these are just sort of large generalizations, even though there are definitely a lot of individual differences within these, but overall, Latino culture tends to be the most collectivist, which is then followed by Black culture, and then white culture, which is the most individualistic. And actually, research studies have similarly shown that the level of collectivism of the care structures mirror that level of collectivism of the larger culture. So the sizes of care structures and the tendency to include friends and neighbors is highest for Latinos, which is then followed by Black families, and then finally followed by white families. And because we talked a little bit about caregiver mental health, generally, let's also talk about how caregiver mental health exists within each of these cultures. Now, caregiver stress, burden, and depression has been shown to be highest in Latino caregivers, followed then by white caregivers, and then followed by Black caregivers. Now, there have been a number of theories about why there are these racial and ethnic differences in the mental health effects of being a caregiver. So Latino caregivers have been theorized to experience role engulfment because of their collectivist roots. So Latino caregivers, in comparison to caregivers from other racial and ethnic groups, tend to become extremely involved in the caregiving process, possibly through the cultural value of familialism. where Latino caregivers sometimes sacrifice a lot of their own personal needs for the needs of the individual that they're caregiving for, maybe even at a rate that's higher than in white or black culture. So for example, Latino caregivers actually tend to delay residential care placements or institutionalizations longer than white caregivers do. But then on the other hand, black caregivers actually tend to experience the highest mental health. Even though there are racial and ethnic disparities for black individuals with stroke, their caregivers actually tend to fare the best in terms of mental health. So there have been a few theories about this. So one is the faking good hypothesis, where black caregivers may experience high rates of mental health issues, but just underreport those rates. So they may actually have much poorer mental health than they're actually leading on in some of the research studies. Then second, there's the positive reappraisal hypothesis, where black caregivers may culturally focus on the positive aspects of caregiving, like maybe being able to make meaning out of their care or out of the suffering. Maybe using spiritual beliefs to help aid in the ways that they cope with the process of caregiving. And then the final theory is the minority stress model. So this theory says that particular racial and ethnic groups, and blacks in particular, experience a tremendous amount of racism and discrimination over the course of their lives. And because of this adversity that they've really been socialized into and have had to grow up experiencing, they have a set of coping resources that other racial and ethnic groups might not, that they were able to hone those resources when trying to deal with those other adversities. So then those coping resources then can play out when they experience future life stressors, such as becoming a caregiver. So we decided then to look into some of our data and see whether these effects were also present in our sample. Now, in this third paper, which we also published in Rehabilitation Psychology, the paper was called Caregiver Mental Health and Racial and Ethnic Disparities in Stroke: Implications for Culturally Sensitive Interventions. So in this study, we wanted to examine the connections between caregiver mental health and some of these racial and ethnic stroke disparities that the literature had pointed out. So in this sample, we used the exact same data set as in paper 2. So again, we sampled caregiver mental health and stroke patient functioning at 1, 6, and 12 months after hospital discharge. And again, we had an ethnically stratified sample, so 124 dyads, where 1/3 were black, 1/3 were white, and 1/3 were Latino. Now what we found was that Latino individuals with stroke, who here are represented by the red line, actually showed the lowest stroke functioning as compared to the other racial and ethnic groups. So white and black individuals with stroke didn't really differ in their levels of functioning, but Latino individuals with stroke across the 3 time points, so 1, 6, and 12 months post-discharge, at each of those time points very consistently exhibited lower functioning. Then when we looked at the mental health of stroke caregivers, we found that black caregivers experienced the highest mental health. White caregivers pretty consistently over time experienced a mid-range level of mental health, and Latino caregivers experienced the lowest levels of mental health. Now this was pretty consistent with some of the previous literature on stroke caregivers. But the most interesting thing that I think we looked at in this study wasn't just sort of documenting things that had already been found in the literature, but we wanted to look at the overall size of the connection between caregiver mental health and stroke functioning by race and ethnicity. So we decided to run what are called canonical correlations. And that's where, as we did in some of the previous studies, you look at the size of the correlation between 2 sets of variables. So the sets of variables here we were looking at were caregiver mental health and stroke functioning. And what we found was that for white dyads, the size of the connection between caregiver mental health and stroke functioning was the largest. Then that was followed pretty consistently over time, even though it flip-flopped at the third time point. But we found that then the next group was Black dyads. And then finally, Latino and Puerto Rican dyads had the lowest connections between caregiver mental health and stroke functioning. Now that was kind of interesting because we found through our other analyses that Latino individuals with stroke had the worst functioning, and Latino caregivers had the poorest mental health. But the way that we interpreted this finding was that really any sets of deficits in individuals with stroke produced high mental health effects on the caregivers. So that was different from some of the other racial and ethnic groups where higher levels of deficits regarding stroke were necessary for higher deficits in mental health functioning of the caregivers. But then if you look down here at the bottom line, which is the correlation between caregiver mental health and stroke functioning collapsing across all racial and ethnic groups in this study, we found that this correlation was actually the lowest over time. So what this means was that when you only look across race and ethnicity as opposed to within race and ethnicity, you lose a tremendous amount of explanatory power. That there's a lot of things that are happening within each racial and ethnic group that you don't capture when you only look across race and ethnicity. So it's incredibly important to use race and ethnicity as a lens for understanding how mental health affects caregivers, how stroke affects the mental health of caregivers, and also stroke functioning. Then in this next set of analyses, we decided to break apart these correlations between caregiver mental health and stroke patient functioning within the racial and ethnic groups. So we wanted to see what the biggest connections were, what the independent variables that were contributing most highly to those connections within each racial and ethnic group. So first here we're going to look at white dyads. At the top we have the caregiver variables, again just sense of coherence, burden, and depression. Then down at the bottom we have the veteran or the individual with stroke variables. We're looking at a VA sample, so that they're labeled here as veterans. But then we have functional independence, instrumental activities of daily living, and depression. Now for white dyads, we found that the highest loading on this correlation, or the individual variables that were most highly driving this correlation, were caregiver depression and stroke patient depression. So in white dyads, the things that were most connected over time were the depression levels of the caregivers and the individuals with stroke. Then when we did the same thing for black dyads, we actually found that there was no very consistent pattern of connections between caregiver variables and individual with stroke variables over time, that the loadings kind of flip-flopped back and forth over time. But then when we looked at Latino dyads, we found that for caregivers, sense of coherence and depression were most highly related to deficits in the individual with stroke regarding the instrumental activities of daily living. So again, these are those kind of higher social and even community-based variables. So the less that a Latino individual with stroke was able to participate in kind of the normal, routine, even social functioning and community aspects of their lives, that was the hardest for caregivers to take, and that most affected their depression levels and their coping ability. So we kind of took into account the findings from previous literature and also our research findings. And we said, okay, it looks like Latino individuals with stroke and their caregivers overall are faring the worst. So what if we develop an intervention specifically aimed at Latino stroke caregivers? Now in this fourth paper, which was called A Culturally Sensitive Transition Assistance Program for Stroke Caregivers, examining caregiver mental health and stroke rehabilitation. In this paper, we developed and implemented a randomized controlled trial of a supportive problem-solving and psychoeducational intervention for Latino caregivers. And we did this primarily with Latino caregivers who lived in Puerto Rico and Texas. So we had 61 dyads, or 122 participants overall. Now, in this study, we gave caregivers a video phone, which we then used to link them up with a a stroke clinician at their local VA hospital. And we had them talk over the video phone with the stroke clinician at 1, 2, 4, and 6 weeks after hospital discharge. And they only did this for 30 minutes for each of these sessions. Now, the sessions involved a couple different things. So at the beginning of the study, we provided caregivers with a culturally sensitive caregiving skills booklet. And we actually walked them through this booklet to help improve overall their caregiving skills. So each of these calls included some skill development, some education about stroke, about the mental health effects of stroke, and about things that caregivers can do to take care of themselves as well as the individual with stroke. And then also problem-solving training, where we helped caregivers strategize about any problems that they were having in caregiving around the home. Now, what we found was that this caregiver intervention actually reduced caregiver strain over time. So the gray line here is the treatment condition, and the dotted line is the control condition. So caregivers who were in the control condition experienced an increase in caregiver strain over time, where caregivers who were in the treatment condition experienced a decrease in strain over time. Then, when we looked at depression scores for caregivers who did not have depression at baseline, we found that caregivers in the control condition ended up developing depression. So in this graph, 10 represents the threshold for depression on this particular measure that we were using. So the caregivers in the control condition actually developed depression, where caregivers in the treatment condition did not. So our intervention had a preventative effect on depression for caregivers who were not depressed at baseline. Then the thing that we were really most interested in looking at was the effects of our intervention on stroke rehabilitation. So here we're looking at motor functional independence measure. So this is motor functioning. And what we found was that the control group experienced lower gains in rehabilitation than the treatment group did. But this was not statistically significant, mainly due to our low sample size. I mean, this was a pilot study, so we didn't quite have the power that we needed. But we did find differences that were in the direction of what we'd expect. So the treatment group tended to gain more functional independence than the control group did. Then, when we broke this apart by caregivers who were high functioning at baseline, so had a FIM score above a 49, in comparison to people with stroke who were low functioning at baseline, so had a FIM score of below 50, we found that people with stroke in the treatment group actually had higher gains than in the control group, specifically for people with stroke who were low functioning at baseline. So in other words, this intervention was most effective for stroke patients that were low functioning at baseline. So this leads us to our last paper. Now this paper was called Comment on Interventions for Post-Stroke Disturbances of Mood and Emotional Behavior. Recommendations from SIGN 118. I know what you're asking, what the heck is SIGN 118? So SIGN stands for the Scottish Intercollegiate Guidelines Network, which is a European body that reviews all of the literature on particular health conditions and then creates formal recommendations for best practices that are empirically supported. So when SIGN convened, they developed a recommendation list for kind of the standard of care for stroke rehabilitation. And I actually got to review this list. So I published a paper reviewing what I thought of their guidelines. Now, their guidelines actually included a very kind of intrapsychic approach. So they reviewed a bunch of studies that looked at the effects of antidepressant treatment on stroke functioning, which had some pretty positive effects. And then they found a few studies on psychotherapy for individuals with stroke. And those studies were, I think there were only about 4 of them, but they didn't show too much benefit. They showed a little bit benefit, but not quite as much as some of the antidepressant studies. So this led the Scottish Intercollegiate Guidelines Network to say that antidepressants should be the standard of care, and a secondary standard of care should be psychotherapy for individuals with stroke. But when I read that set of guidelines, I realized that they really were not taking into account any racial and ethnic variation in stroke rehabilitation, or even the caregivers. So my criticism of this set of guidelines was that it's absolutely vital to include caregivers in stroke rehabilitation. That because caregiver mental health and stroke functioning are so intimately related, you can't just treat stroke functioning and try to rehabilitate the individual with stroke. That you also have to adopt a systems lens and treat the system in which an individual with stroke lives. And the primary way that you can do that is the caregiving system. So you provide mental health interventions for both caregivers and individuals with stroke. And then what that does is actually improves informal care for the person with stroke. And then finally, it's incredibly important also to incorporate cultural background and cultural sensitivity in stroke rehabilitation. That because there are wide racial and ethnic differences in stroke rehabilitation and even in care, you can't approach stroke rehabilitation with just an ethnically blind lens. You know, one of the most fundamental philosophies of culturally sensitive interventions is that as opposed to healthcare providers coming in and saying, well, we know what's best for interventions for this particular racial and ethnic group. Instead of doing that, the fundamental philosophy of culturally sensitive rehabilitation is to help improve the social systems and social supports that are already in place for that particular racial and ethnic group. So here the most direct way of doing that is by helping to improve the mental health of the caregiver, and then as a result you improve the social system that the individual with stroke actually is rehabilitated within. Now, because a lot of our studies happened in the Department of Veterans Affairs, and a lot of other caregiving research has also happened there, the VA has actually been instrumental in involving caregivers in the rehabilitation process. So I just found out that the VA has established a national caregiver support line, not just for caregivers of veterans with stroke, but for caregivers of veterans with all types of disorders and disabilities. Now this is incredibly important and innovative of the VA. And what I would argue is that other rehabilitation facilities and healthcare systems should follow suit. That providing health services to caregivers of individuals with disability is incredibly vital and will absolutely help to produce rehabilitation gains in individuals with disabilities. Now, that's the end of my talk. If you have any questions or comments, please feel free to email me. My email address is pperrin@vcu.edu. Thank you very much for tuning in.